Okay. All right. Good evening, everyone, and welcome to the National Coalition of 100 Black Women Health Committee program entitled Connecting the Dots and Understanding of Cancer Disparities in Our Community. So just a few housekeeping rules. We'll ask everyone to stay on mute. We'll ask you to place your questions in the chat box as they will be answered during the question and answer session. And also we'll have a brief survey. It'll likely be sent to you by email after the program, and we'll ask you to complete that. Let me move this. Okay, so just a little information about the National Coalition of 100 Black Women. Our purposes are to foster principles of equal rights and opportunities, to promote the awareness of Black culture, to develop the potential of the membership for effective leadership and participation in civic affairs, to take action on specific issues of national and international importance, and to collaborate with other persons and organizations to achieve mutual goals. The vision of the National Coalition of 100 Black Women Incorporated is to see Black women and girls live in a world where socioeconomic inequity does not exist. The mission of the National Coalition of 100 Black Women Incorporated is to advocate on behalf of Black women and girls to promote leadership development and gender equity in the areas of health, education, and economic empowerment. The health initiatives, our priority focuses are Childhood and Family Obesity Initiative, NCBW Cancer Health Disparities Program, NCBW Metabolic Syndrome Initiative, Prevention, Decrease Mortality, Improve Health Outcomes, Access to Affordable Health Care, Culturally Competent Research, and Quality of Life, Public Safety, and Crime. I have the pleasure of having one of my colleagues here today to talk with us about cancer disparities. I will do a brief introduction on him. We have Burke J. Brooks. He earned his medical degree from LSU. He completed his residency at Charity Hospital in New Orleans and his fellowship at the National Cancer Institute's Warren Grant Magnuson Clinical Research Center in Bethesda, Maryland. He is board certified in internal medicine and medical oncology, as well as by the American Board of Internal Medicine, Medical Oncology. Dr. Brooks has been on staff at Ochsner since 1987. His leadership positions at Ochsner have included Chief of Medicine, Chief of Medical Subspecialties, Chairman of the Research Committee, membership on Research Advisory Committee, and was a former member on the Board of Governors of Ochsner Clinic Foundation. He also holds an elected position on the Board of Governors of Ochsner Clinic Foundation. Dr. Brooks has written many articles for scientific medical publications and has written chapters for several oncology textbooks. Dr. Brooks' expertise is in lung cancer, breast cancer, treatment and prevention, and cancer genetics. Everyone, please join me in welcoming Dr. J. Brooks. I will switch over to your PowerPoint now, Dr. Brooks.
Thank you very much, Angela.
Oh, you're welcome. Let me
All right.
Stop sharing my screen real quick.
You're running the show.
I am. Give me just a moment. I'm going to get that other PowerPoint going. Okay, where's my other PowerPoint?
Okay, well, good. Thank you all very much.
Yes, it took a while.
All right, so let's go ahead and do next.
Okay.
So let's just talk a little bit about cancer in general. So cancer is common. 1 out of 3 of us in our lifetimes will develop invasive cancer. More of us will develop non-invasive cancer. For instance, myself, I mean, I've had a skin cancer in my lifetime, but cancer is common. Cancer increases as we age. As the population ages, more and more people will develop cancer. The long-term survival rates of cancer have improved dramatically. Just to give you some numbers so that you can understand this, in the last 7 years in the United States, cancer death rates across the entire population have fallen 3.5% per year for the last 7 years. That's an incredible public health improvement. And that's to the credit of better screening, better prevention, and also better treatment. But I think it's a real testament to the long-term view of decreasing smoking rates. In the state of Louisiana, nationally, about 14% of people smoke cigarettes. In the state of Louisiana, we're at about 21%. So it's important that we constantly, continually, ad nauseum, tell people to quit smoking. And I think it is absolutely the namesake of our organization, Ochsner. Alton Ochsner in 1939 first linked tobacco with lung cancer. And that's really been the forefront of leading this organization and leading the nation to try to decrease tobacco exposure. So, I've spent my career trying to do that. And so we'll talk a little bit about that as we go through the talk. So go ahead and advance. So this is cancer in Louisiana. And so if you look at our state, you'll see that our state is a hodgepodge of colors. In the top left of your screen, you see that certain parishes have higher cancer incidence than others. And when you superimpose a map of the state in reference to poverty, you will see that this closely matches up. And so it's really important to understand that a lot of cancer today is a result of poverty and economic inequality. More people who smoke, who use tobacco, are usually people who have less income, unfortunately, and less education. And so it's a critical thing for us to understand that tobacco is such a powerful cause of cancer that it is absolutely the #1 driver of cancer deaths, which we'll look at on the next slide, but it is absolutely so critical. On the right side, you see the most common cancers in Louisiana: prostate cancer, breast cancer, and lung cancer. So it's kind of interesting when you look at that, you'll say, well, gee, I didn't anticipate that there were more breast cancers than there were lung cancers. And if you had taken this slide about 10 or 12 years ago, you would have found that there was far more lung cancers than there are today. Starting about 10 years ago, the number of lung cancers in the United States and Louisiana began to decline. And the reason for that is the many years of tobacco education, tobacco prevention, raising tobacco taxes on packs of cigarettes, where we clearly know that for every $1 you raise of taxes on a pack of cigarettes, you decrease the consumption by about 12%. It's a very powerful tool, and it's something that we can do as citizens of the state to help decrease tobacco consumption. You'll see those little vertical lines, and that's sort of where national averages are. And you can see that in some of our cancer incidences, we are above the national average. And some of them we're actually quite close or even below the national average. And number one is you look at breast cancer, we're sort of right at the national average. Lung cancer, we're above it. Colon or rectal cancer, a little bit above. Some of the other cancers, such as non-Hodgkin's lymphomas, we're actually below the national average. So understanding cancer is not a monolithic description. It has several different components to it. And I'd like to credit Louisiana because for over the last 50 years, we have had a very, very important tool in our state, the Louisiana Cancer Trust Fund, which funds a tumor registry in the state. Only about half the states in the United States have the vigorous program that we do in Louisiana that studies and records the number of people who actually have cancer. In the state of Louisiana, anytime there is a biopsy done in any facility, whether it be a hospital or an outpatient facility, 4 times a year, the state tumor registry comes in to record those numbers. So one of the reasons why we know so much is we actually record the number of cancers that we have in the state. Let's move to the next slide. And please stop me. We're a small group if you have any questions as we go along. So cancer is a disease of aging. And you can see on the bottom graph, as we age, it sort of peaks at around 80 years of age. That's the highest incidence of the disease. We do run higher differences in incidence by race and also by sex. As you can see, white women tend to be around average in the state. Black females are a little bit higher, but both men who are Black and white in this, the way we describe this demographic, are higher than the national average. And Black men in this state have the highest incidence of cancer of any group that we have. Let's move on to the next one. So the key in discovering cancers is finding them early. And so, unfortunately, as you can see, only in the Baton Rouge area, Jefferson Parish, or actually St. Charles Parish, and in St. Tammany Parish, do we have a really a better group of people that we detect earlier. Unfortunately, most of the state, we're still not detecting cancers at an early enough stage. As you can see in the bottom right, there is a predominance of Black men not being discovered as an earlier stage. So it is really, really important that we try to focus on the groups that are not being discovered early. Go ahead, next slide. Cancer survival actually is here it clearly shows that the further along a person is in the disease process, if you're discovered earlier, you have a much, much better survival than if you're discovered at a later stage. You can see that in the bottom left hand curve. You can see that differences in survival affect all of us, though in Black individuals in this state, that is the lowest group of patients in terms of survival. And the reason for that is discovering cancers at a much later stage. The key in cancer is discovering cancer early, and by effectively doing screening tests with CTs of the chest for lung cancer, mammograms, Pap smears, and also prevention with HPV vaccine. These are all critical ways that we can reduce the incidence of cancer and improve the discovery of cancers at earlier stages that we can radically import the survival to our patients. Let's move to the next slide. So survivors of cancer, which is an incredible group of people today. We now have hundreds of thousands of people in this state who are survivors of cancer. And as you can see, obviously, the number one is prostate cancer, followed by breast cancer, and followed by colon or rectal cancer. So we have a group of people in our state that can really be the advocates for truly telling their story to other people about what they can do to diagnose cancers at an earlier stage. My brother is 54 years old, and he was diagnosed with prostate cancer. And he is an attorney for a large law firm in the southeastern part of the United States. And the other day, the managing partner asked him, "Can you tell the story of how you were diagnosed with prostate cancer?" And so he was very brave and went on a Zoom call with probably about 300 people in his law group to tell his story. We need to share our stories with people, because cancer used to be a taboo disease. My mother, who died early last year, used to call me, and she would say, "You know, Mrs. Jones, who lived down the street, she has cancer." And there's this incredible sense of fear, dread of the C word. And I think individuals in our society who are willing to share their diagnosis, share their story, can truly help others with earlier diagnosis and importance of, when you do have an early diagnosis, of the importance of improved overall survival. So I think it's really, really critical for us to tell our story, to use our own individual life story to affect others, to help them with the screenings that we have, to tell people to get screened so that you can, if you're diagnosed, you're just diagnosed at an earlier stage. Next slide. So let's talk a little bit about cancer today in 2022. Next slide. So these are some graphs that come from the advisory board, which is a very large think tank in DC that advises healthcare organizations. Ochsner is a member of this. Cancer is a common disease, and it's a disease that will increase over the next 10 to 20 years. As our population ages, you can see in various cancers, lung, hematologic, melanoma, brain, the increase that you can expect to see in the growth of cancer incidence in the United States. Next. We are going to have an incredible toolbox to discover cancers early. Liquid biopsies, we're going to talk a little bit about that at the end of the talk, about something that Ochsner is going to be bringing into the Baton Rouge community in the next several weeks and months. This is where blood tests. You take a tube of blood, and tumor cells shed pieces of their DNA that we've now been able to identify specific pieces of that DNA, and through a blood test, detect the potential for earlier diagnosis in cancer. So this is a very exciting area, because for many years, people would ask me, is there a blood test for cancer? And until very recently, there wasn't. But there are some very interesting studies that are going to be coming out that are going to be using this DNA technology to detect earlier cancers. One of these is called GRAIL, and we're going to talk a little bit about that and how we're going to bring that to the Baton Rouge community, and actually bring that to some of our community health centers in Baton Rouge in a research setting so that we can help our patients. Go ahead and move forward. Now, the pandemic has been unbelievable. I've been a cancer doctor for more than 30 years, and in the last year, I have seen more advanced cancers than I have ever hoped to see again. And the reason for that is patients were very frightened of coming into the healthcare system, understandably so. There was a tremendous pressure on the healthcare delivery system. So many screening tests, mammograms, colon screening, lung cancer screening, have all really taken a very dramatic nosedive. And when we do that, cancers that are more advanced develop. And that's what, unfortunately, we've actually seen over the last several years since with the pandemic, really shutting down screening from early 2020 until it really began to sort of come back toward the third and maybe even the fourth quarter of 2020. So it's been a dramatic decrease in cancers, but the cancers are there. They're just bubbling up now in a much more advanced. So let's go ahead and move forward. So these are some quotes from colleagues around the country, but this is really where we are today. The number of, especially in breast cancer, where we've really decreased the number of early cancers detected because of mammograms. We've seen a dramatic increase in the number of advanced cancers compared to years past. This is something that we as leaders in the community need to really encourage ourselves, encourage each other to get back into the screening for cancers so that we can really affect survival by getting cancers discovered at an earlier age, not in the advanced stage that we've seen over the last. Next slide. So this is, again, the dramatic increase in the number of advanced cancers that we have seen. And if people did not believe that screening worked before, and it was just a way to drive people to doctors' offices, and that it really impacts survival, it impacts the care that we deliver patients with the number of dramatically advanced cases that we've seen. Forward. So I think we've now pretty much shown this with the effects of COVID-19, and we've got to really work hard to encourage our patients to get back into the routine screening that we need. Go forward. Okay, so let's talk a little bit about the future. So we here at Ochsner have partnered with a company that has developed what's called the GRAIL test, and it's a blood test that you're going to draw, that you're going to be able to that's going to be able to detect a number of early cancers early. We're still not going to recommend discontinuation of screening. This is going to be another tool to layer on top of patients to try to detect cancers at an earlier age. Go forward. So this is a blood test that is a multi-cancer early detection test that detects a common cancer signal across 50 different cancers. So this is a list of the cancers that a blood test, if it is positive, leads you to look at that particular type of cancer with a more intense screening tool. It doesn't supplant the screening tools that we already have. It's another test to layer on top of it. So these are the 50 cancers that we'll be able to look at in the near future in terms of another way to screen for early detection of cancer. Go forward. So here in Baton Rouge, there are going to be 3 ways to access this. We've just begun a project where you can do this test. It's going to cost you $800. That's one way of doing it. But we're going to do several trials with this company to look at this test in the Baton Rouge area. We're going to bring this through many of our cancer centers, many of our community health centers we have in Baton Rouge that we partnered with the Drew Brees Foundation on. And these are going to be places in the community that patients can have this test done as part of a research trial for us to better learn how to use this test going forward. The company that developed GRAIL specifically wanted to partner with Ochsner because of the geographic and also the racial diversity that we have in our patient population, that we can use this to try to study how does this test work in a larger group of patients. Again, this is a test that is FDA licensed, but we're learning how to do that and to layer this on top of the existing screening tests that we have. Go forward. So this gives you a little bit of some of the early work that was done. If you have a positive test, it has a sensitivity of about 50%, but the specificity is about 99%. So if you have a positive test, it's a very, very good indication that you're going to have a malignancy. If you have a negative test, it doesn't mean you don't. And so that's why we want to continue with the current screening test. As we learn more by doing the research trials, both here in Baton Rouge and also in the Ochsner Health System, we will be able to better understand how this test can be layered on top of the existing screening test to better understand how to detect cancers at an early stage. Go forward. This just gives you some of the different types of ranges of sensitivity and specificity for some of the types of cancer that we do. Go forward. So in this particular type of test, cancer is not detected. It does not mean that the patient does not have cancer, only that the test didn't identify. So it's critical that these patients continue with customary screenings. If a cancer signal is detected, it means that we need to look at other more sophisticated screening tests to detect cancers in these high-risk individuals. One of the things we've learned is that cancer screening is great for the general population, but when we can better understand the patients who are at a higher risk because of a genetic predisposition, we have much better tools that we can use to detect cancers earlier. To give you an example, so if you have a very strong family history of breast cancer, blood tests today can detect genetic mutations. We can use mammograms, we can use MRIs to detect earlier breast cancers. We began colon cancer screening at a much earlier age in people who have colon cancer in the younger population. I'll just make a general statement. Cancer screening for colon cancer should begin at age 45 for the general population, and 10 years before colon cancer was detected in a family member. So we're already using those specific types of individual characteristics to study particular types of patients to give them the advantage. This tool will help improve upon that as well. Next slide. So this is one of the tests is we're going to be doing this as part of a study. It's going to be part of a responsibility that we, Ochsner, have to the community. We're going to be purchasing about 6,500 tests at about $650 each. And that's our financial commitment to try to understand how this test will help our community, especially in places where we don't screen as well to detect earlier cancers. These are going to be some of the sites that we're going to be using this, and you'll be hearing more about this over the next, several weeks. There was a story in one of the New Orleans TV stations concerning this test, and within 48 hours, we had 2,000 people calling already. So we're going to be bringing this out a little bit more slowly in the Baton Rouge area, so we don't get inundated like that going forward. Next up. This is a little picture of the team that we have. These are many of the physicians here in the Baton Rouge area, the nurse practitioners, the APPs here in the community that serve our patients in the Baton Rouge area, both from our medical, surgical colleagues. And so I want to congratulate them, and it's truly an honor and a privilege to work with them in trying to take care of cancer in the Baton Rouge area. I think that's my last slide. And I'll be happy to open any questions.
Anyone have any questions for Dr. Brooks? That was a lot of information. I know everyone is trying to digest all of it.
So the message is cancer screening works. We have to do it, and we have to share our stories about why it works, how it's affected us in our lives. Everybody's frightened of cancer. I'm frightened of cancer. But I think it's important for all of us to do the screenings that we need.
Okay, see if I can get this off of here.
So the question is from Sagan is great information. How do we, can you put, let me get that back up again?
Okay. Can you see it?
Yeah. How do we normalize conversations of screening and prevention? It can be difficult to minimize fear. Absolutely, 100%, I agree with it. And cancer is an incredibly frightening word. And so I think we have to tell stories of, like, say, I was frightened. This was my concern. My brother being diagnosed with prostate cancer was basically about a year of him having an abnormal PSA. And I must have talked to him 20 times about what it means, why to do this, why to do that. And it's a process that you go through. It's not something that happens instantly overnight. And so it's something that we need to talk about and to really identify the cancers that we're concerned about. Number one is tobacco. Tobacco represents 1 out of every 3 cancer deaths in the United States. Being a healthy weight with a BMI less than 30 means it reduces the risk of cancer by another 20%. That's half the cancers in the United States by those 2 things. Having a colonoscopy. I've had 3 colonoscopies. Next year, I'm going to have my 4th. That's important too. I have a PSA test on a yearly basis. I have a skin exam on a yearly basis. I've had a basis. I don't smoke. I don't get a CAT scan of the chest. I don't need to do that. But those are important things that we need to talk about. In both the female and the male population, being vaccinated against HPV up to the age of 45 dramatically reduces the risk of cervical cancer, anal cancer, and oral cancers by almost 90+%. So these are things that we can do that can help prevent cancer and that we can tell our stories to each other.
Okay, there's another comment in the chat. It says, also, can you speak to people that will minimize the use of tobacco in comparison to vaping or other alternatives? What would you suggest as treatment preventative measures for tobacco smoking cessation?
So one of the things that Ochsner has done is inside of our system, and Angela as an Ochsner physician can tell you, once you're identified as a smoker, every time we see a patient, we are reminded to put people into our tobacco cessation program. It's free to our patients. We've used the money from the EP settlement a number of years ago to help fund this. It takes an average of 11 times before someone quits smoking. That's an average number. So that means half do less, half do more. So it's important that if someone says, I tried to quit, but I couldn't, you say to them, okay, I understand it. It's an incredibly addicting drug. Just yesterday, the FDA is trying to minimize the amount of nicotine, which is an addictive drug in cigarettes. And the tobacco companies are going nuts because they know this is the drug that makes people want to smoke. So that's why it's so very hard for many people to quit smoking. Vaping is a terrible illness in our society. Yesterday, I think the FDA today actually is going to ban juul vaping. Vaping has a whole nother set of problems with it. It's just a different nicotine delivery system for people. It probably has less of a cancer risk than tobacco, but we don't know the long-term effects. We clearly know that there are many complications of lung disease, not necessarily cancer, related to vaping.
Okay, thank you. There's another question. Delayed screenings during COVID caused an increase in cancer. How long does it take for cancer to form or show up in the screening process?
If you knew that answer, you win the Nobel Prize. So some cancers are much better in terms of a slower growth. Most colon cancers start as a polyp or an abnormal growth in the colon and slowly over many years develop into cancer. Some breast cancers develop very slowly. There is a certain type of breast cancer called triple negative breast cancer that affects African Americans more than Caucasians, but affects both. That tends to develop more quickly than does the routine breast cancers that are responsive to hormone therapy. So it's hard to say. Lung cancers, the vast majority of lung cancers start as a single spot in the lung and grow and spread. That's why routine low-dose CAT scan screening for lung cancer is so important. Actually, Ochsner 15 years ago was part of the research trial that led to the discovery of that. Actually, CT lung cancer screening affects survival more than actually breast cancer, because lung cancer is such a serious and deadly cancer, whereas breast cancer tends to grow more slowly. So that's something we don't do as well. I think inside of our society, there is a prejudice against smokers, but CT low-dose screening is so important in detecting early-stage lung cancers.
Thank you. Sandra has a question about genetic testing.
So genetic testing there are two types of genetic testing. There is genetic testing of the tumor, and we do a tremendous number of genetic tests on the tumor. One that you may hear about is called next generation sequencing, where we actually look at the genetic profile of tumors. And in about 5 to 10% of patients, we can actually change the way we treat patients. We also use genetic testing to be able to better predict, especially in breast cancer, where we find that most women with the most common type of breast cancer, where we used to give chemotherapy to them, 80% of those women do not need chemo, and they can just take a hormone pill to reduce their risk of cancer going forward. So we use that, and we'll use that more in the future. Genetic testing of the blood tests the predisposition, or what we call the germline, whether or not you have an increased hereditary risk of developing breast cancer or colon cancer or other types of cancer. I saw a young woman the other day who had a cancer of the uterus 20 years ago, and now she has a bladder cancer, and she was not a smoker because bladder cancer is usually associated with tobacco. And so when I talked to her about her family history, there were 2 family members who had colon cancer. So we do a blood test on her, and it turns out she has what's called Lynch syndrome, which predisposes her to developing certain types of cancer. This past year, I had a patient that I diagnosed with Lynch syndrome 30 years ago, 30. He had 13 cancers in his lifetime. He just died after his 13th cancer. So genetic testing of the blood is very important in people who develop cancers early or who have multiple cancers in their family.
Sandra, did that answer your question?
Yeah, but I have another question too.
Okay.
Hey, Dr. Brooks, I'm a breast cancer survivor.
Uh-huh.
I'm 49. I finished treatment last year.
Okay.
I was HER2 positive. I
Okay.
did chemo, I did radiation,
Uh-huh.
and thank God I'm doing great.
Uh-huh.
Into tamoxifen now.
Okay.
I guess my kind of like genetic question, they did do the genetic testing and I wasn't predisposed to any other cancers. Since that time, I had my colonoscopy, which everything was good.
Good.
I guess my question is more or less my mother and my daughter. Should they have genetic testing?
Okay, so great question. So did you have a blood test that looked at the genetic of your blood? It's like MyRisk or usually test for about 30 to 35 genes.
I think so.
Okay, well, you should have a copy of that. The doctor should give you that.
I do.
If you had that in 2022, that's the best that we can offer.
Okay.
In 2032, there may be 300 tests we do, but we don't know that.
Okay.
You already had a genetic evaluation of your tumor because you were HER2 positive and you were treated probably with a drug trastuzumab, or the trade name is called Herceptin. And if you're estrogen receptor positive, you're doing another genetic test on your tumor that you take a pill now for at least 5.
Yes, I am.
So you're benefiting from the genetics of testing the tumor, and you've also, your doctor's ordered, and rightly so, the blood test to see if there's any reason to this date that we understand that. We don't understand all of cancer, but we are beginning to chip away at the edges. And so your doctors did everything right.
Okay, good deal. So my mother and my daughter, as far as testing.
I mean, as far as not that I'm aware of. Now, your daughter, you have to ask her father's side of the family, what was their type of, what did they have cancer?
Yeah.
So you have to understand the genetics of breast cancer. The genes that are associated with the genetics of breast cancer are called autosomal dominant, which means that both men and women inherit the genes equally. They may not be expressed the same. You're a woman, I'm a man. We both have breasts. Your risk of breast cancer as a woman is 200 times greater than me. But there are 200,000 new cases of breast cancer in the United States in women and about 1,000 new cases of male breast cancer. So the genes can be passed down, but not expressed in men.
Okay. Thank you so much.
Thank you. Okay, so the next question is asking, is it true that chemically straightening your hair or relaxing may cause cancer?
Well, since you're talking to a guy who ain't got no hair, that's a hard question. But I don't know that that's been really shown to increase individual risk of an individual. I don't know that.
Okay, thank you. So the next question is, can some patients take the Grail blood test for free, or does it cost for everyone?
So right now, I mean, we're bringing this. Eventually, the company that develops the test is going to win and make money. There's no question about that. But the question is, they're wanting to learn more about it. So there are going to be 3 ways to do this. You can do this commercially. You can go to your doctor and you can get a Grail blood test. Number 1. Number 2 is there are 2 research trials that are going to be done inside of Ochsner to get the blood test for free. And those are going to look at certain demographic groups to see, does this test perform as well as it does in others? We don't know that
Okay, thank you. Do we have any other questions for Dr. Brooks?
I don't have a question, Sister Angela, but I have a comment. Dr. Brooks, I actually work at the Breeze Family Center. I'm the community engagement person for Ochsner. And we do offer smoking cessation in our center. So it is free. If anybody wants to come and make an appointment, we would love to have you. I'm gonna do my commercials too.
Go girl, go girl.
But we're also in the process of ramping up our screenings. So that is something that will be rolling out in the fall with the JAG-Mobile, a partnership we're working on with Southern University. So we will be more than excited to offer those screenings and, help you get signed up for anything, any needs that you have. Not only medical needs, but, if you have some social determinants of health, things blocking you from resources that you need, the community health centers are there, open and operating to assist in those areas. So thank you, Dr. Brooks, for coming and sharing about cancer, because this is something that we are ramping up with our screenings, and we want to get into the community and meet people where they are and offer these types of screenings. So I appreciate you.
Make sure you tell Sarah Delaney I give her a hug tomorrow morning.
I sure will. I'll see her tomorrow.
All right. Let's see. Yes, so we have great presentation, Dr. Brooks, and thank you, Dr. Brooks. Great job.
All right.
And I agree. Thank you so much, Dr. Brooks. That was some great information. And I must have been at work that day that news presentation came out about that Grail testing, because we must have gotten hundreds of questions that day. And honestly, I just learned about the Grail testing in April when I went to a medical conference. So yeah, the community got that information and they were already asking questions. So we can't wait. You got it
now.
Yes, we got it. So can't wait for that to roll out. So anyone else have any questions or any comments for Dr. Brooks before we close things up? Nothing else? Okay. Well, again, we'd like to thank Dr. Brooks for sharing his expertise in the field of cancer. That was a lot of great information, and everyone had a lot of great questions too. So thanks to everyone for your questions that you had. Just some on the screen, if you want to help with our programs, the NCBW programs, you have it here and you can scan it. We would appreciate any help to support our future programs. And this is just to save the date. And Dr. Brooks, you're probably not even aware of this yet, but it's in the works right now that we're going to be doing with Ochsner, our breast cancer awareness program at the Grove on the 5th floor from 11 to 1. So that's being worked on now, working with Valerie Anderson. So she's helping us put this together. So there'll be more information to come on this. We hoped that it's going to be a big event and hope that it's going to be something that we can do every year at Ochsner. So more information to come on that. I would like to take this time to thank our sponsor, Blue Cross Blue Shield of Louisiana. We definitely appreciate their support in our programs. And I'd like to thank the Health Committee for all of your work this entire year. We have put on a lot of programs in a short period of time, and all hands were on deck, and we really appreciate our committee. Everyone has worked really hard. And our Madam President, Courtney Hunt, has already spoken, but I don't know if she wants to say anything else on behalf of her presidency or not. Courtney?
No, I'm sorry, I was on mute. I don't have anything else to say besides congratulations, ladies of the health committee. You guys have done an amazing job getting through this program year, and Dr. Brooks is like the icing on the cake. So I'm very excited about what's to come in our upcoming year. So I appreciate you, Madam Chair.
So I'm going to leave you with a little thing that I had on my desk for many years. So this is what it looks like. And it says, cancer cures smoking. So what you want to make sure is, please tell people to quit smoking.
Yes.
It's the absolute number one thing we can do is to help each other decrease this incredible burden.
Yes, yes. Thank you. Thank you for that. We also have Madam First VP Dinesh Piper on the call. Do you want to say anything, Madam First VP?
No, sisters. I think that Madam President said it all, and thank y'all for gracing us with your presence at this event. And well, congratulations, Health Committee.
Thank you. Thank you. Okay, and thanks to everyone for joining us. And this will wrap up our programs for this program here. This was the last one, and we will be starting back up, after August. We'll let you know when the next one is, but most likely, as I mentioned, it will be the Breast Cancer Awareness Program in October. So thank you, everyone, for joining us. Thank you again, Dr. Brooks. I'm forever grateful. A lot of information, and wish everyone a very good evening and stay cool.
That's right.
Yes. Good night.
Good night.